NCLEX review for nursing students. This is video 4, so please make sure you watch videos 1, 2, and 3. And we're just moving along in small segments going through the fundamentals class. And I'm highlighting the important concepts that you really need to understand and you need to be able to integrate into the NCLEX questions as well as your nursing school class examinations. So we're going to talk about oxygenation now. And we're going to start with hypoxemia. So remember that breathing is one of our ABCs. Airway, breathing, circulation, 2 of our ABCs. So we always need to be assessing our patient's oxygen status and being able to identify signs and symptoms that our patient might not be getting appropriate oxygenation. So hypoxemia. What is hypoxemia? The definition is low oxygen in the blood, in the arterial blood. So the only way you can really diagnose hypoxemia, looking at the oxygen in the arterial blood, is to have an ABG drawn. Now, we can have hypoxia, we can have decreased oxygen in the tissues, and this is how you would go about taking a pulse oximeter to see if the patient is hypoxic. But normally, sometimes people interchange these two words, but understand that hypoxemia is low oxygen in the arterial blood, and you need an ABG to diagnose this. So remember some other terminology. Ventilation is the air moving in and out of the lungs. Okay, so we want our patients to have appropriate ventilation, moving air in and out of the lungs. Diffusion is the exchange of gases, and that happens in the alveoli of the lungs. And the exchange of gases goes from the alveoli to the capillaries and out through the heart. And we're going to talk more about the heart and how the blood flows later on. So perfusion is how well the exchange of gases between the blood and the tissues is actually happening. So we want good perfusion, we want great exchange of gases between the blood and the tissues, we want appropriate diffusion, hopefully our lungs are working appropriately, and then we want appropriate ventilation where our lungs are able to move in and out of the lungs. So if you're working with a patient and you start seeing early signs of hypoxia or hypoxemia, you really need to alert the provider and then start doing nursing interventions. So some early signs might be that your patient starts to become restless or irritable or feeling anxious. The patient might feel like he's trying to breathe out of a small straw. So if you were breathing out of a small straw, you probably would be panicked, have some anxiety, not really know what's going on. So if your patient's fine 1 minute and then starts being agitated or restless or trying to pull tubes and drains out of himself, take his pulse ox. So late signs, you're going to see a change in the level of consciousness. You might see some cyanosis, some bluish colors of the lips, or maybe when you do your capillary refill, it doesn't come back within 3 seconds. And then we need to also be aware if we start oxygen therapy that our patients are receiving the appropriate amount of oxygen, because with certain levels of oxygen, it can actually be toxic for the patient. So we need to make sure that our patients, if they show signs and symptoms of hypoxia and hypoxemia, that we get an appropriate order for their airway and oxygen levels. So we know that patients who are immobile, we already talked about this, are at risk for collapse of the lung. If you lay in bed all day and don't get up and walk around, your lungs aren't going to be as strong as they were when you are up and walking around. So one activity that we have our patients do, especially after surgery, is we have them use the incentive spirometer. So on the left, here's a picture of the incentive spirometer. So they put that mouthpiece in their mouth and they take a deep breath in. It's an incentive spirometer. And we see how high there should be a ball in that cylinder or some sort of measuring device. And we want to see how high we can get that ball. We tell our patients to do this like 10 times an hour when they're awake. If they're watching TV, they can do it during the commercial breaks. But this is just good exercise to get their lungs expanding and moving any fluids that they have in there up and out. We also can teach them how to deep breathe and cough. If they've had surgery on their abdomen, we can teach them how to splint that surgical site so it doesn't hurt. It's not too painful to take a deep breath in and then cough. And of course, to increase their ability to have great gas exchange, we need to put them in a high Fowler's position to expand those lungs as best as we can. So of course, we're only going to do this with a patient who's alert and oriented. So all of our assessments beforehand have to all pertain to alert and orientedness. And if it's a safety risk, of course, we're not going to do this. But our goal is to have patients in high Fowler's, having them deep coughing and breathing, deep breathing and coughing, using the intensive spirometer, and then hopefully getting out of bed and walking around. So with COVID, I don't know if you guys heard, but one of the positions that they would put the COVID patients in, the really sick COVID patients, is prone, face down, because this is actually really useful in inflating the lungs, like down at the bases. We try not to do that. So we like high Fowler's. So we're trying to prevent that lung collapse. We're trying to inflate those alveoli as best that they can. And of course, getting the oxygen in the body to really help those red blood cells out, and then hopefully having a great pumping heart to get that blood all throughout the body. So again, 10 times an hour with the incentive spirometer. If they only do 8, that's fabulous. But our goal is 10 times an hour. Most patients don't do it 10 times an hour, but we like to educate. That's the best. So we have different types of oxygenation devices that we can put on our patients to help them keep their oxygen saturation above 95%. So we can use a nasal cannula, which is usually attached to the wall behind their bed. I'm sure you've seen this with the 2 prongs. When we put patients on a nasal cannula, we like to use a water-based lubricant in the nares. We don't use oil-based with nasal cannulas or oxygen. We don't like oil-based. We like water-based. And the reason we do this is to prevent drying of their nose, because having that oxygen in your nose for hours and hours can really dry you out. Then we have a non-rebreather bag. One thing to know, we're going to go through these more in depth in a minute, but you need to understand with a non-rebreather bag that the bag needs to be fully inflated before you put the bag on the patient, and I'll show you a picture of that. A partial rebreather bag does not need to be fully inflated. It can be 2/3 full. And then a Venturi mask, a Venturi device. It's attached to another piece, and think precision. So a Venturi mask, you can be very accurate and precise of the amount of FiO2 that you are giving to your patient without intubating them. So nasal cannula, non-rebreather, partial rebreather, and a Venturi device or a Venturi mask. And we're going to go through these more. So here's a picture of a nasal cannula. The 2 prongs here go up the patient's nares. Many times you'll walk in and these 2 prongs are on the patient's forehead or under their chin. So make sure they are in the nose. So who needs a nasal cannula? So a nasal cannula, you can see it's small and it's a flexible tube with the 2 prongs. It just goes right inside the nares. This tubing is attached to an oxygen source, usually on the wall behind the patient, or I'm sure you've seen the oxygen tanks out in the community. So the oxygen concentration that we use with nasal cannulas is relatively low. We do have high flow cannulas, but with these, really, you're on like 2 to 4 liters of oxygen with a nasal cannula. These are less invasive, and we don't have to put a face mask on the patient because that can be very irritating. They can't really eat or drink or talk with the mask on. And so we like to use them. So people who have asthma or COPD, or sleep apnea or cystic fibrosis or pneumonia, who really don't need high flowing oxygen, can usually get away with a nasal cannula, and usually between 2 and 4 of oxygen. So next is the oxygen mask. Like I just said, you can see how it kind of goes over the whole nose and mouth, and it can be annoying to patients. So usually you'll see these on top of the forehead as well, or down on their neck. have to reinforce that that needs to be over their mask, over their mouth. And so the purpose of a mask is to deliver low flow of oxygen, kind of like the nasal cannula. It can be a little higher. We can do like 5 to 10 liters per minute on a mask, and we can do a concentration of about 28 to 50% of a flow rate. So a little higher concentration. Just make sure your patient keeps it on, because like I said, patients love to take masks off. Now a Venturi mask, here's a picture of a Venturi mask with an apparatus here where you can tubing. So who needs a Venturi mask? A Venturi mask is a high flow mask. So they create enriched oxygen by mixing the oxygen in the room air. So when we're worried about a patient's CO2 or carbon dioxide retention, we're going to put them on a Venturi mask. Like I said, we can keep COPD patients maybe during the day on a nasal cannula at a lower level of oxygen, but if they're really air hungry, we can put COPD patients on a Venturi mask. So it's going to be based on a doctor's order, and if the doctor is really worried about the patient retaining too much carbon dioxide. So here's a rebreather mask. As I told you in the first slide, before you put it on the patient, the bag needs to be 100% filled up with air. So who needs a non-rebreather? So non-rebreather masks are designated to deliver a lot of extra oxygen to the airway. So the normal FiO2 that you and I breathe has a concentration of about 21%. But when you place a non-rebreather mask on a patient, you can provide up to 60 to 91% FiO2. This mask has a very tight seal around the nose and the mouth, and it's only a one-way valve for this mask, so that you only breathe in the gas from the tank. So like the Venturi, you can breathe the tank oxygen as well as the outside oxygen. This is only the tank oxygen. So people who are going to need a non-rebreather are like people who are in house fires. So breathing in smoke can seriously damage your lungs. Of course, it's going to cause swelling and inflammation of the airways. So we need to get as much oxygen down into the lungs that we possibly can. So we need to put on a non-rebreather for this patient. And then maybe patients with end-of-life COPD, or patients who have really a low functioning respiratory system. So you're rarely going to put on a non-rebreather, but just know that it's for people who really need higher FiO2, like I said, between 60 and 91%. And actually, there's some studies that have shown that a non-rebreather actually does help with cluster headaches. So getting as much oxygen down there into the body as possible has been shown to be an effective treatment. So that was an interesting fact. So again, with the non-rebreather, it's only used in patients who can breathe unassisted. So they have smoke inhalation, or they have some damage to their lungs, but they are still able to breathe on their own. So again, we're talking about in a fire, so they've inhaled smoke, or at their end of life COPD, or if they have that cluster headache like we talked about, or if maybe they just had some physical trauma, like they were just in a car accident. So the patient can still breathe on his or her own, but there's just some trauma that has made the lung tissue swollen and inflamed. So a partial rebreather mask, here's a picture here. And like I said in the introduction, the bag only has to be filled up about 2/3 of the way. And who needs a partial rebreather? So this mask has a two-way valve, and it's similar to a non-rebreather. But the difference is that the valve that I showed you on that picture that connects between the reservoir bag and the face mask. So there's a two-way valve instead of a one-way valve like the non-rebreather. So this allows the first third of the breath that is exhaled to get into the reservoir bag, and the remaining exhaled air flows out and it goes into the atmosphere. So you're not keeping all the same breath in the bag. Okay, some is getting exhaled into the atmosphere. So when you breathe again, the first part of the exhaled air is inhaled again from that reservoir bag. So the first 1/3 of the exhaled air is the air held in that dead space, the space where there is no exchange of air in the lungs, and that is the trachea. Since the air is formed from the dead space, it contains unused oxygen. And so a partial rebreather saves 1/3 of the CO2 that the patient exhales. So when the patient inhales, they breathe that CO2 back in. And then this has the effect of stimulating their breathing, stimulating their own breathing to get better, which makes their oxygen intake even easier. So a partial rebreather, we would put this on a patient who's experiencing hypoxia, some sort of respiratory disease or cardiac disease or shock or trauma or severe blood loss or seizures. So again, this person is able to breathe on his or her own. It's not as severe as inflammatory or swelling that they need a non-rebreather, but they need to not only breathe the oxygen in the tank, but they need to breathe some of their exhaled CO2, because CO2 stimulates our brain to start breathing better. So this will stimulate our brain to start breathing more efficiently on its own. So we talked about, so here's a difference between a CPAP and a BiPAP. You probably know that CPAPs, a lot of people use CPAPs at night who have sleep apnea. And then a BiPAP, we're going to talk about that. So a BiPAP is, it provides continuous pressure, but the pressures are different between the inhalation and the exhalation. And it's not really used in the field or at home due to the complexity of the device. It really needs to be monitored, and it's very expensive. So you'll see people on BiPAP in the hospital where they can have respiratory therapy, really monitoring this machine. Versus the CPAP, so this offers continuous pressure as well, but the same pressure is kept during the exhalation and the inhalation. And this is used in the field and at home because it's less complicated. A lot of people use this at night for sleep apnea. It doesn't really need that much monitoring, and of course it's less expensive. So sleep apnea, so when we put on a CPAP for a patient, it provides continuous positive airway pressure, and it uses a tight-fitting mask that is attached to like a ventilator. And the patient receives continuous pressure, splinting airways and reducing alveolar collapse. And like I said, it's usually good for sleep apnea. It keeps those airways open. The problem with sleep apnea is that patients forget to breathe or don't breathe at night. So this keeps their lungs kind of expanded and open, and keeps that positive pressure on the lungs so that the patient does continue to breathe. Versus a BiPAP, here's a picture of a BiPAP. So it's a positive airway pressure, just like the CPAP. It's not invasive. It delivers kind of the same thing as a BiPAP, but the pressure is different. It delivers both inspiratory and expiratory pressure instead of just the inspiratory pressure. So somebody who has a chronic pulmonary illness, such as COPD, might be placed on a BiPAP. If the patient has any neuromuscular conditions that impair the respiratory muscles to work, such as ALS or muscular dystrophy. And then therapeutic oxygenation. So there are different ways that we can help other than putting a mask or a nasal cannula on a patient. There's something called chest physiotherapy, and this is done with patients usually with cystic fibrosis. They have a lot of drainage. So what we do is we percuss on their back. We produce a vibration to get all those secretions out. So it's a special technique that you can be taught how to do. We try not to do it like right after the patient eats because they can become nauseated. But that it's called chest physiotherapy. You know, people with cystic fibrosis, they do have a lot of secretions in their lungs, and it can be hard for them to breathe. So we can do this this percussion and vibration on their back to kind of help break up that secretion. We also have suctioning devices. I'm sure you've seen at the hospital. There's always a suction device above the patient's head in the hospital room. And we can use this to remove secretions in the patient's mouth, any blood in the mouth. If we are suctioning a patient who has a tracheostomy, and they're on a ventilator, what we really need to do before we suction anybody through the trach is that we need to pre-oxygenate them. At least we have to give them 100% oxygen before we do this. Because when we're suctioning, we're actually removing all of the oxygen from the patient's airway, and that can be very scary, and that can make the patient very anxious. It's not a good, safe feeling. So we need to make sure that we pre-oxygenate that patient with 100% oxygen before we suction. We're going to apply suction as we withdraw the catheter. We never apply suction when we're going in, only when we're coming out. And we're not going to use continuous suction. We're going to use intermittent suction as we draw that catheter out of the patient. And we're only going to do this. We're only going to suction about 10 to 15 times per pass. Like I said, you're suctioning out all the oxygen in the patient's lungs. It's not pleasant. It's not comfortable for the patient. So we're going to do this as fast, but as efficiently and safely as we possibly can. So chest tubes, you need to know about chest tubes, and we're going to talk about this more when we talk about med-surg, but chest tubes are drainage tubes, and so we use these where we need to collect fluid or air from the lung. So there are different types of chest tubes, like there are dry chest tubes and wet chest tubes, and we're going to learn about this, like I said, later. But what you really need to understand is that NCLEX loves to ask questions about bubbling in the chest tube. So we're going to go deep into these later on, but what you need to know is that when a chest tube is placed, we need a chest x-ray to confirm that it's placed properly. There are tubes that come from the chest tube down to these chest tube collection devices, and we never want to clamp that tube. We never want to milk or strip that tube. And that our collection devices that are sitting here on the left, they always need to be flat on the floor below the patient's chest. So we're going to learn all about these later, but we never really clamp or strip or milk the tubes. They're always flat on the floor below the patient's chest. So like I said, we're going to learn more about chest tubes as we go further in this class, but here's just an NCLEX question for you to look up so you can be prepared before we get there. A patient has a chest tube and you notice continuous bubbling in the water seal chamber. What would you do next? Is this normal? Is there a leak? Are we going to have the patient lay flat? Are we going to discontinue or disconnect the chest tube and wait 5 minutes and then reconnect it? I'll let you guys look that up so you're prepared for our next lecture on chest tubes. So we talked a little about a tracheostomy on the last slide. So as a nurse, you're going to perform tracheostomy care. And what you need to know is that tracheostomy, we're always going to touch the tracheostomy using a sterile technique. Okay, anytime we have to clean around the tracheostomy, we're going to clean from the stoma outward. Again, this is always done with a sterile technique. You can use what's called split gauze when you redress the tracheostomy dressing. It's a 4x4 with a cut down the middle. And then just understand when you educate your patients about home safety. Of course, with oxygenation, we never want to have smoking around the oxygenation system. If we're using an oxygen tank, the tank always needs to be upright and secured on the wall. We always use water-based lubricants, again, no oil-based. We want to wear cotton clothes to decrease the risk of starting a spark. And of course, any frayed electrical cords or outlets we need to get repaired or replaced ASAP because we are very worried about fires, especially with that